What's going on, ladies and gentlemen? It's your boy Nurse Bass back with another video. And in this video, what I wanted to do is I wanted to give you guys an idea of what my ICU shift report looks like on a day-to-day. Let's dive in.
Are you listening? Nurse Bass. Beast mode. Grinding.
I want to preface this video with a few things. As I'm going through this video, as an example of what my shift report looks like, I'm going to be talking fast, and I want you to understand that is not how I would give a report. I'm doing that purely for the purposes of saving time and not having you guys sitting here for 25 minutes as I regurgitate a hypothetical made up scenario of a patient. I need to preface it with the fact that I take my time, and I purposefully take my time because I want to make sure that the receiving nurse is understanding everything that's going on with this patient. Because I myself, as a newer nurse, have been on the receiving end of somebody who's giving me a report who is just rattling off at the speed of light, like I'm likely going to do in this video, and it is so insanely impossible to absorb the information in any kind of proper way. You're gonna miss stuff. So for the sake and benefit of the receiving nurse, try and give your report in a nice, slower manner. Let me know if I'm going too fast, and just try and explain things nice and easy. Another thing is that I want you to understand this has been one of the biggest, not pitfalls, but one of my biggest insecurities in my nursing career for probably the first 3 years of my career is how I would always feel inadequate whenever I'd be giving a report. It's one of the most difficult things I feel like for newer nurses, especially working in critical care, to try and wrap your head around all of these critical care concepts as a newer nurse and then try and regurgitate them succinctly in a report that is in a sequential chronological order that makes sense. And then the final thing that I would say as I preface this video is that one of the most important pieces of advice that I got from one of my first preceptors in ICU was to, as you do your report, from beginning to end, every single time, try and do it the same way. As you do it the same way over and over, eventually that repetition is going to become embedded in your brain, and your ability to give a proper and effective report is going to get better. But nonetheless, as we dive into this video, this is all going to be a made up scenario of a patient, nothing real at all in this scenario. And honestly, some of it may not even make sense because I'm just I'm freestyling this thing. Okay. So nonetheless, how do I start the report? Okay. First thing is basically the face sheet of general information. This is Mr. Smith. He's a 56-year-old male. Full code. What's the code status? Full code. Patient of, what service is the patient a patient of? Critical care, heart failure, nephrology, let's say. Then I would say past medical history. Past medical history is significant for hypertension, hyperlipidemia, diabetes type 2, COPD, on how many liters of oxygen at home, if you know. On 3 liters of oxygen at home, history of AFib, on Eliquis at home, anticoagulation, chronic kidney disease stage 3 with a baseline creatinine of 1.7, if you know that. Again, some of these pieces of information, such as how many liters of oxygen, if they wear that, do they take anticoagulation, what's their baseline creatinine, it gives the oncoming nurse an idea of how far away from baseline is this patient today.
Hey guys, real quick, I just wanted to let you all know about this amazing company called nursing.com, whose sole purpose is to help prepare aspiring and new nurses for success in this rewarding career. Links down below. They have 4 brand new academies available for whatever stage of the grind you're in. The Pre-Nursing Academy for those aspiring, the Nursing Student Academy for those in the trenches, the absolutely stellar NCLEX Prep Academy with over 99% pass rate, and a program designed to help the new grad nurse navigate this new and intimidating profession. Just pick the path that's right for you. But if funds are tight, don't worry, because nursing.com has a ton of other free resources available to you as well. One day, patient lives will be in your hands. Study like it. Links are in the description. Love you guys. Grind on.
And then whatever other medical history there might be. Allergies, no known allergies. And then we'll dive into what the heck brought them here. So again, I'm off the top of the head here. Mr. Smith was at his primary care physician's office, initial vital signs as they were getting taken. He appeared to be short of breath, and as he was getting his initial vital signs taken, he had O2 sats in the upper 70s on his home 3 liters of oxygen. So the primary care physician ended up calling EMS, and he got transferred here to our ED. En route, EMS put him on a non-rebreather without much recovery of his sats. So upon arrival to the ED, he got placed on BiPAP. Then we're going to talk about what happened, or what initial diagnostics or lab values got drawn. They got a chest x-ray on Mr. Smith. It showed pulmonary edema. He was very fluid overloaded. Initial lab values of BNP, B-type natriuretic peptide of 500, troponins of 150. Cardiology has since been consulted. It's likely demand ischemia. What did they do? They gave 80 milligrams of Lasix. He didn't diurese much at all, maybe 100 mils of urine. Ended up getting transferred up here to our floor. Let's say he was still doing bad. He was still decompensating. Cardiology's involved. This patient gets started on a Lasix strip. He gets interventional cardiology on board. They end up taking him down, dropping a Swan-Ganz catheter, a pulmonary artery catheter, so that they can measure the pressures in his heart. Patient's basically in cardiogenic shock. His respiratory status further declines as he's not having any effects from the Lasix, so they ended up having to intubate him on this date. And again, as I'm talking, I'm going very slow, and I'm also giving dates as if I have them of every chronological thing that has happened in a nice proper order so that it makes sense. Patient got intubated on this date. Great recovery of his SATs. They started him on propofol and fentanyl. They ended up having to start him on milrinone, a positive inotrope, so that they could, just for your guys' information, greater squeeze of the heart. This guy's in heart failure that I'm basically making this story I'm making up. So anyway, you go through everything that's happened in a sequential order. Then, okay, well, where are we today? Then you start going through vital signs, right? Temperature is this. Heart rate is this. What's the rhythm? Also, you tell them. What's the blood pressure been? You tell them. What are the blood pressure goals if they're on vasoactive medications, vasoactive drips? You tell them. What are the saturations been? They've been satin great. Okay, and I usually will say vent settings and all that for the assessment piece. Again, I do this in a very particular order. So we're going straight vital signs. Afebrile, he's in AFib because he's chronically in AFib. Heart rate between 80 and 110s. Blood pressures, his means have been above 65 the whole time, which is our goal. Systolics, like let's say 120s to 140s, and he's been satting 99% on the vent. Then I would go over to the assessment. I would start with neuro. Patient is intermittently following commands. We have a RAS goal of -2. Intermittently following commands. Pupils are equal round and reactive to light. He'll nod appropriately. He'll squeeze your hands and wiggle his toes. Good cough, good gag. Then I move into respiratory. Patient has coarse lung sounds up top, diminished in the bases. ET tube 25 at the lip. Vent settings 40% FiO2. PEEP of 8. Rate of 18. Having moderate ET tube secretions, thick and creamy, scant oral secretions, clear and white. Moving to cardiac, I've already talked about the rate and the rhythm. So then, we would mention edema. Patient is edematous. He's in heart failure, fluid overloaded, cardiogenic shock. So edema, bilateral upper extremities and bilateral lower extremities, +2, +3. GU, patient has a Foley catheter in, chronic kidney disease. Creatinine's starting to climb. We'll get into that with labs, but not having much response from the Lasix that he's on, so urine output's only been 10 to 15 mils per hour. Nephrology's aware. GU, patient has an OG tube to low intermittent suction. I've had 400 mils out on the whole shift. It's this color in nature. Patient has hypoactive belly sounds. Abdomen is soft to palpate. Then maybe I would dive into skin, would be probably one of the last components. No skin issues, we'll say. After I've gone through the assessment in a very particular order, I would then go into lines. I would go into lines. So patient has a left IJ central venous catheter, triple lumen, and here are the drips that we're on. So this is when I would mention it. So in one port, we've got propofol and fentanyl going for sedation. Propofol is at 40 mics. Fentanyl is at 150 mics, and we got sedation there. He is on pressors, right? So the second port, let's say we've got, we got phenylephrine going at this rate. We've got vasopressin on board at this rate, and then we've also got milrinone for the inotropy at this rate. Those are all compatible. We're making sure that all of our meds, our drips that are going through each individual line are all compatible with one another. Then in the third port is the Lasix strip. Okay, and then he's also got left radial art line. It's flushing well, good blood return. It's correlating with his manual cuffs. It's been working well, knock on wood. Also got 2 peripherals, bilateral extremities, both saline locked. And then we've got a right IJ Swan-Ganz catheter. It is at, let's say, 52 centimeters. That's something that you always want to note if you're working in CVICU or you're caring for patients who have pulmonary artery catheters. You always want to note where it is marked at. Should it ever become malpositioned or your waveform starts looking weird up on the monitor, this thing is malpositioned. This is a bad issue because this is something that's going through the heart up into a pulmonary artery. So any malpositioning of that is a big issue. So anyway, Swan-Ganz catheter is at this marking. Something else I didn't mention also, because I just forgot, but also dating back to vital signs, that's when I would have also brought up all of our Swan-Ganz numbers. All right, all of our pulmonary artery pressures, our cardiac outputs, our cardiac indexes, so on and so forth. This is more of a general ICU report, so I know CV is not going to be applicable to everybody, but nonetheless, that's when I would have also, under vital signs, I would have mentioned all of our cardiac numbers as well. So these are all of our lines, and I just mentioned them all. So after lines, this is when I would go dive into labs. All the labs that we've been drawing, any labs that we might be trending, anything that is pertinent for this nurse to know that may fall on their shift that they need to do, that they need to be aware of, that is something that I'm going to mention there. And pretty much after that, at that point, it's like, what's the plan for this patient? What has been cardiology's input? What's critical care's input? Are we trying to extubate this patient, or are they not prepared to be extubated? Cardiology, this patient's on milrinone. We're going to keep them on milrinone. Cardiology is going to round this morning. We're going to see if we can make any up or down titrations on this milrinone. What does nephrology want to do with this LASIK strip? So on and so forth. And so that's just kind of the way in which I would give report. And then maybe if you wanted to drop miscellaneous information in there about anything family related, because family is always, a component, then that may be something that you would mention as well. But what is the plan for this patient? What are we doing right now? Like, where are we going? That's always something very important to communicate, of course. So that's kind of how I give a report. I hope that this wasn't too jumbled of a video. You'll have to forgive me for maybe some intermittent cuts and edits because I don't have my paper right in front of me, but you always do things in the same order every time. It's going to help you re-solidify the way in which you give report in your mind. You're not going to go as fast as I did. You're going to go nice and slow so that the oncoming nurse can digest what you're saying. And you're always going to ask if they have any questions at the end, because you want to make sure that you're leaving this nurse in a nice, successful spot and that they don't have any further questions that, maybe you could bring clarity to, since you were just with them for 12 hours. I hope that you guys enjoyed this video. I hope that it helped maybe for some of you new critical care nurses, or maybe those who are aspiring. For what it's worth, there it is. It's your boy Nurse Bass. I hope that you enjoyed the video. Please be sure to like, because it helps with the algorithm. Subscribe if you're new to the channel, and I look forward to seeing you guys on the next one. We're putting out more videos every week to motivate, uplift, and inspire you to be the best damn nurse you can be. That's all I got. Peace.